Aloha, everyone. We'll get started in just a moment. People are still logging on. Aloha, everyone. We will start in just a minute. I see there's a few people still logging on.
Hello. Can you hear me?
Yes. Hi, Dr. Baker. Welcome. We are
Oh, no,
just
not
starting.
doctor, please.
Dr.
No.
Baker, Senator Baker. We're getting off to a great start. Thank you for joining us, Senator Baker. And
Sure.
I apologize for the wrong, calling you the wrong thing. We
Oh
are.
no, I just don't want to be a doctor in this day and age.
Blame you. Well, with that, we will go ahead and get started.
Okay.
Thank you so much, everyone, for joining us today. We're having this webinar today to look at what's happened with the Our Care, Our Choice Act. It's amazing to think that it's been in effect for over 2 years. It feels like just yesterday we held a press conference in which John Radcliffe was the first person in Hawaii to make an oral request, and that was over 2 years ago. And so I am very honored to be here today with people who have been part of this journey. Senator Baker, who's been part of the journey much longer than I have here in Hawaii. And we're going to talk today about the number of prescriptions that have been written. We have Laura Arcibal with us from the Department of Health. We're also going to be talking with the care coordinators and patient navigators from Kaiser, Hawaii, and from Hawaii Pacific Health. They have been generous enough to share some of their data with us to help us understand what is happening on the ground here in Hawaii. And I can tell you from the implementation work we've done, both Kaiser and Hawaii Pacific Health have really done a tremendous job at implementing the law and making sure that eligible patients who want the option are able to access it. And I'm really grateful that they're here today and will be sharing their experiences and the data that they have. What's interesting with this law is that we're finding in Hawaii, like we have, there's 9 other states in Washington, D.C., all have similar medical aid and dying laws. And many patients who go through the whole process never actually use their medication, but just having it on hand gives them a great sense of relief. And not everybody's eligible for medical aid and dying. So in order to be eligible, you have to be terminally ill, you have to be 6 months or less to live, have the prognosis of 6 months or less to live. You need to be a resident of Hawaii, and you need to be mentally capable of making decisions as well as able to self-ingest the medication. In addition to that, you have to make 2 different oral requests made to a physician separated by a mandatory minimum 20-day waiting period. There's also 2 written requests that a patient has to make. And so there's many steps along the way. So without further ado, we are very lucky to have Dr. Charlotte Sharfin with us today from the Big Island. Dr. Sharfin was the first doctor on a neighbor island to write a prescription. And she is on call, so we don't know how long we have her for. So I'm going to go ahead and hand the virtual mic over to Dr. Sharfin.
Thank you so much, Sam. I am really happy to be here, and I apologize if I do have to scoot really quick. But just so you do understand my background, I'm an emergency physician. That is my board certification. I have been doing that for 20 years. And it led me to the Big Island, and it led me to realize how our culture tends to be so afraid of death and not want to talk about it. And that led me to start a nonprofit called Life and Death Wellness, which is how patients actually found me. None of the patients that I have helped have actually been my private patients. And I have now helped 6 people go through the entire process. And I'm really grateful for the law, because I do believe what it does is it improves end-of-life care in general for everyone, not just the people that are going through it. And it opens up discussion like I've never seen before. So when it works well. But when it doesn't, it's actually it's really unfortunate. And I want to tell you about a couple of those stories because I think what we can do is do better. Like I said, I'm really grateful that we have this law, but I think there are ways to improve it. So the first patient I want to tell you about, I call him the captain. He was a patient with metastatic cancer, quite terminal. He had a very supportive oncologist, but unfortunately that oncologist was within a system that thought they didn't allow their physicians to be prescribing doctors, which actually turned out not to be the case. But that's why they found me, because they were told their doctor could not help them. And when I met the captain, I could tell he was declining rapidly. And I honestly didn't know if he was going to make it through the whole process. And I'll never forget, we did this all via telehealth because of the pandemic. And he was lying on his couch and he said, "So doctor, are you telling me all I have to do is stay alive and wait 20 days and stay sane?" And I said, "Yeah, that's pretty much what you have to do." And I honestly didn't think that was going to happen for him. And that's one place where I think our law can be improved. 20 days is actually too long. We're the only state that actually has that requirement, and there's no scientific proof that that's actually even a legitimate waiting period. But nevertheless, he surprised me. He made it to day 20. And we were kind of high-fiving, I would say, through the screen. This law was so important to him in ways I didn't fully understand, but for him to be able to have access to this medication was really one of his last dying wishes. It gave him some little bit of control over something he really had no control over. And it was heartbreaking to get the phone call from his wife the day I wrote his prescription. She said, "The captain has fallen. He has hit his head. He's not making any sense." But the last thing he said to me was, "What is today and when will I get my medication?" And then he died. And he died surrounded by his loving wife. He died in hospice. So I have no doubt that he died supported, but I do know that he died without something he really was really important to him. And so I do believe he's the first, I've seen the Department of Health's recommendations. I've agreed with all of them. But I'd never had a patient that really, I could say, "Oh my gosh, this is somebody I would choose to waive the waiting period. This is somebody that could really benefit from decreasing the waiting period." So he was a perfect example for me, how important it is to make changes in our law that help improve access. Because on the Big Island, we are a rural island. The other patient I want to talk about, and every patient that has a story, okay, they all do, and they all could have benefited from having more providers on this island that were willing to engage in this law. We know that Hawaii has a shortage of physicians in general. That's been my experience as long as I've been here. And we have even less on the Big Island, and we have even less that are willing to actually help their patients for multiple reasons. No judgment there, but I really think Gary's story illustrates how important it is to have other providers like APRNs be able to be involved in the law. Gary was a patient on the east side of the island, 2.5 hours from me, that found me. I'll never forget him telling me, "I had to call Oregon to find you, Dr. Sharfin." He had a primary care doctor. Gary was also terminal, and his doctor had told him, "I'll help you in any way I can." And Gary actually thought that meant he would help him take him through the law. They had talked about that. So Gary made his first oral request. Gary went out on his own and got a psychiatrist to evaluate him, had his consulting doctor. He did every step along the way. He had done his research. And on the day he went back to make his second oral request, his primary care physician that had been taking care of him for years said, "Oh no, I'm sorry, I don't do that. And you should either go home and die naturally or drink a bottle of Benadryl." When I heard that story, I was mortified. When I heard that story, I was so sad because that is not how we treat patients, right? And I think any physician that engages with this law is extremely compassionate and they want to help people in a way at the end of their life. I did help Gary. It took a long time to get him through the process, but he made it through the process. He was my first patient that actually accessed the medication. All of my other patients had not. And the last thing Gary said to me was, Dr. Sharfin, make me a promise. Make me a promise that nobody else is going to have to go through this like I did, that nobody's going to have to wait this long. And that's one of the reasons I'm really grateful to be here today, to be able to talk about Gary and share these stories, because I do think we need change. Again, I'm grateful we have the law, and I'm honored that I've been able to participate since since the beginning. So that's it. Thank you.
Thank you so much, Dr. Sharfin, and thank you for being supportive of patients on the Big Island and for making time today in your busy schedule to share your stories. I wanted to let everybody to know that this panel is being recorded. And if you have questions, we will have time for questions and answers at the end of the presentations. In order to ask a question, there's a box on your screen. So just put your question in that box, and then I'll read the questions at the end. And we're copying and pasting them and putting them in a Google document. So if it says your question got declined, don't be nervous. It's just that we're collecting all the questions, because sometimes people ask similar questions, so we combine them. All right, next we have Laura Arcibal from the Department of Health, who will be talking about the data and Department of Health's recommendations to the legislature.
Aloha, everyone, and hope you are all well. I'm Laura Arcibal, currently serving as the State Telehealth and Healthcare Access Coordinator at the Department of Health. I'm also serving as staff to the Our Care, Our Choice Board, and have been involved in the DOH's implementation of the law since prior to the law going into effect. The department collects and report on data on qualified patients who received a prescription. I am undergoing my initial evaluation on the 2020 data, and at this time I can share the following information with you. There's been a total of 66 qualified patients who received a prescription since the law went into effect on January 1, 2019. In 2020, there were 36 patients who qualified and received a prescription, 24 of which ingested the medication. The majority of patients are over the age of 65 in hospice and were suffering from some form of cancer. They were predominantly white, Caucasian males. Access appears to still remain the same, a challenge for neighbor islands. Less than 5 participating providers are located on the neighbor islands, of which Kauai appears to be the least represented. Large, well-connected health systems such as Kaiser and Hawaii Pacific Health appear to have the shortest wait periods and quickest turnaround times for patients, from the patient's first request to the date of the written prescription. In 2020, the average waiting period from the patient's first oral request to the date of the written prescription is averaging about 45 days compared to 29 days in 2019. The longest being 210 days. The top 3 longest days were from private practicing providers. Those days are 169, 179, and 210 being the longest. The slight increase may be attributed to new participating providers, but after looking, I thought that would be the case, but after really looking at the data, these providers, there's only one of those that were new. So the DOH, our recommendation remains the same. As reported in 2019, waiver of any waiting periods if the attending provider and consulting provider agree that the patient death is likely prior to the end of the waiting periods. And second, being given access to healthcare providers is limited, that the DOH recommends authorizing advanced practice registered nurses to serve as attending providers for patients seeking medical aid and dying. And that's my recap for today. Thank you, Sam.
Thank you so much, Laura. And thank you for all the work that you've done at the Department of Health. I know you've been working on this for a long time, even before the law went into effect. So thank you. We're grateful for you. Next, we're going to hear from Susan Amina, who has essentially helped overseen Kaiser Hawaii's end of life option program. And Susan has some slides that I will be sharing. So let me share my screen. There, can everyone see my screen?
Great, thanks, Laura. So my name is Susan Amina. I'm a nurse practitioner at Kaiser and am a cancer care coordinator, as well as one of the coordinators for the medical aid in dying program. We're fortunate that we have a great team and we're able to be fairly well coordinated with this process. We've had a total of 85 requests, pretty stable from 2019 to 2020, 43 and 42. About 80% of those actually have had the diagnosis of cancer, 68 cancer patients. Fairly split on the neighbor islands, so about 15 on the Big Island, 13 on Maui. And again, because we've got providers both on Oahu and neighbor islands that can complete this process, that's been very helpful. 5 patients total have been actually ineligible for the program. 3 because of prognosis and that they did not meet the 6 months or less prognosis, and 2 in terms of mental capacity, in terms of not having the decision-making capability. To date, so this data is as of December 31st, 2020, 39 prescriptions have been written, 35 have been dispensed. We've had a total of 61 deaths, 25 from medical aid in dying and 35 from natural causes. We did have 1 suicide, and that was a referral that we received. And the next day I called to try to do an educational appointment, and he had actually committed suicide the night before. So for a total of the 2 years, we've had 16 people who've died in that 20-day waiting period, so about 24%. That was 16% in 2019 and 34% in 2020. So again, like others have said, it's just really unfortunate that we have this number of patients who died without having this option. So that's our data. And again, we'll just reiterate, the need to really have the consulting and attending have the ability to waive that waiting period.
Thank you so much, Susan.
Thank you.
And I have to say, similar to what Laura said, we know Kaiser, Hawaii Pacific Health, when a patient requests medical aid in dying, what happens is they are supported internally to, first of all, make sure they're eligible, and then, make sure they can get through the process. And not every health system does that. Not every, and not to put blame on anyone, right? Everybody's overworked, but it's hard to imagine if there's patients who don't survive the mandatory minimum waiting period, at Kaiser or Hawaii Pacific Health, it's going to be that way no matter how great of an internal process you have, because I don't think it can get better than Kaiser and Hawaii Pacific Health. So next we will hear from Michelle Cantillo from Hawaii Pacific Health, and I have her numbers up here.
Hi, good morning, and thanks for having me here. I'm a nurse. I'm the Advanced Care Planner Coordinator for Hawaii Pacific Health, and I also help facilitate Medical Aid in Dying, Our Care, Our Choice Act through the last 2.5 years, even before we started, making sure policies and education went into place for our providers, basically, and our staff. In terms of the numbers, I'll talk through some of the stories with the numbers as well. So basically, I capture all the data of all the patients who are kind of inquired and wanted to start this process. That's 51 patients, and we just had most recently 1 patient this month in the process. A majority of our patients are oncology cancer patients, 78%. The other patients fell into failure to thrive, a lot of elderly patients with failure to thrive, 10%. We had 2 ALS patients and pulmonary fibrosis, and then 1 patient with cardiomyopathy. Part of our process is huge, but our physicians do the education up front. However, we know, for example, our oncologist time is very limited. So what they'll do is consult the social worker, who then says, okay, hey, we have another palliative care physician. Do you want, or provider, do you guys want to proceed, to go through the whole picture with the patient, their goals of care conversation. So of those 51 patients, 68% have chosen to see another physician for that. Again, this is not mandatory, something they have chosen to do. We highly, like Sam had mentioned, we encourage all of our patients for end of life to educate them about hospice and enroll in some kind of a hospice program. Many of our patients, especially the oncology, they start first with our concurrent care or supportive care program, and then chose when they've stopped their medications or treatment to then enroll fully with hospice. So of those eligible patients, 32% says, yes, I want to move forward. They met the requirements. They did their first oral request. And talking about those patients within that 20-day windows, we had 5 patients expired before that 20-day window. Outside of that, we had maybe 26 days, 29 days, and a little bit further. Some patients did say, after much education, maybe one because of the long process, maybe it's like, oh my, I thought this was faster for me. They have chosen not to enroll and continue that 20-day process. Some patients, after much education about hospices and fully enrolling and seeing the services hospice provide, also choose to not pursue to the second oral request. Currently, one patient is doing her bucket list and traveling, so she hasn't come back and given us her second oral request yet. So, but she knows that's pending. So out of those 32 patients, 24 completed their oral requests, and again, same thing, some have died in the process before the medication is written. One patient actually lost their capacity through that process. So again, you gotta wait for that 20-day window. So patients who actually got the prescription from us is 17 patients. And in terms of physicians prescribing this medication, we are still limited. We started this in 2019, where maybe I had 3. Maybe we're up to like 15 people saying yes within our system. We want to give the medication, but that number is really low. You could see in Laura talked about Kauai, 4 patients got the medication in Kauai, but they were prescribed. Only one of those patients were prescribed by a physician in Hawaii. The other 3 were from Oahu. And it's nice for this 2020 with telehealth, and I hope that continues moving forward, that those patients with limited access, the Kauai patients, the Maui patients, we have oncologists that go to Maui, they have no access for our attending physicians. So most of those patients that have got the prescription was from a Oahu physician who says, I will be your attending physician. So there's limited access. So all in favor of getting APRNs on board for that. I just wanted to also share an experience with one of our Maui patients. He was an oncology patient from a couple years ago. And the attending physician, family med physician said, yes, I want to help my patient, but I don't know where to start. So she started by trying to reach out to her own colleagues within her system. And basically there was barriers. She had nobody to speak to. And so she reached out, she saw the patient had a Straub oncologist. She reached out to our oncologist, and he said, oh, Michelle, can you work with this physician? And I was like, absolutely, that's what we're there to do. Our bottom line is to help support our patients and help them through that process. If that means helping our physicians, whether it be HPH, Queens, Maui, whatever, we're there to help support that. And that was my job. So along with helping this physician, and we work together with Maui Hospice that has had more patients as well. We worked together, but for that social worker and nurse, it was their first patient. So it's a matter of teamwork. And for that hospice, that Maui patient did pass away from getting their medication. So and I did have a debrief with that Maui physician. I said, hey, now that you've had the experience and the process was smooth and everything went good, were you able to talk to your other colleagues now that kind of resisted? And she's like, I don't really want to, I feel kind of uncomfortable. I don't want to bring up that discussion. So there's where we have to do more and do more education. So bottom line, 11 of those patients that got the prescription did ingest the medication and passed away. And then 4 of those patients declined rapidly. 2 declined, 1 went into the nursing home, and 1 patient lost their capacity. So thank you so much.
Thank you, Michelle. And thank you for all the education you do. I got to tell everybody here, we do a lot of clinical education and public education at Compassion and Choices. In fact, this evening we're doing a clinical education about Our Care, Our Choice, and many people speaking on this panel will also be speaking tonight. And so thank you for spending your time, because education is so important. And, most doctors don't learn about end of life when they go to school, about how to have end of life conversations, about end of life options. And, there's still doctors who see death as failure, which is crazy because we're all going to die. And I think that's, one of the beautiful things about medical aid in dying is that it helps people have those conversations with their doctors, and so that they can also realize there are other end of life options available to them. I'm very honored to have Laura Reichart here with us today from the Hawaii Center for Nursing. Laura's going to talk to us about advanced practice registered nurses and why they should be able to support patients in this option. Thank you, Laura.
Thank you so much, Sam. I appreciate being invited to this panel today. The Hawaii State Center for Nursing, we are a state organization. We're within the UH Manoa School of Nursing. And what we do is look at workforce issues related to nursing, including scope of practice issues and how many nurses we have. So we have some great information to share today. First, I want to talk about APRN. So APRNs have at least a bachelor's degree in nursing. They have to have a license as a registered nurse, and then they complete graduate education in an advanced practice role. So it has to be specific to the type of advanced practice role that they are seeking to practice in. And complete that graduation or complete that education from an accredited school of nursing, pass national boards, and then become licensed. And only then can they call themselves an advanced practice registered nurse. Commonly, we refer to these people as nurse practitioners because that's how many, we have the majority of our APRNs in our state are nurse practitioners, but there's also nurse midwives, nurse anesthetists, and clinical nurse specialists. And for the purposes of medical aid in dying, it would probably be clinical nurse specialists and nurse practitioners who would be engaging with patients. They have their patients are most likely the type of person who may be interested in medical aid in dying. We have about 1,000 of them in our state, and about 80% are in direct patient care roles. So we have about 800 practicing nurses in the advanced practice role. We have nurses in that advanced practice role in every county, and more importantly than every county, and Dr. Sharfin mentioned it when she was speaking, is that there are shortages of providers across our state. But when we look at where APRNs are working, we have an APRN, we have APRNs in every area that people are living. And so we are well distributed across the state, not just in the urban centers across every county or every island, but across the entire island. APRNs already have very good scope of practice. And this is very important to medical aid in dying. And that question is, well, do APRNs know how to identify if somebody is at the end of their life? Are they capable of prescribing? Can they write an order for a controlled substance? These are questions that people have. We have very good laws for APRNs in our state, very good, some of the best in the nation. We're a very fortunate state. And I should say thank you to Senator Baker for championing our scope of practice. But that has enabled us as nurse practitioners, as APRNs, to assess, diagnose, and treat, including prescribing medications and controlled medications. So we have the ability through our state scope of practice to evaluate patients and also to prescribe medications that are appropriate for whatever we deem to be their medical condition or state. We do have the ability in our state to prescribe controlled substances, and APRNs, because we start off as nurses, we are grounded in nursing practice. APRNs have that understanding of end of life. Nursing really focuses on that compassionate conversation, patient education, helping patients transition to different phases of their life, whether it be from being pregnant and then becoming a mother. That's a transition. We also help patients who may be well transition to that chronic state and then also to that end of life state. So helping patients transition to different stages in their life is something that we are trained, and it's in the foundation of our training. And so that being able to assess a person's condition and state within that continuum of life is something that we have been trained to do since the beginning of nursing. And then as nurse practitioners, we also advance and deepen that understanding and our ability to assess and diagnose. And I say we because I am also an APRN myself, in addition to representing the Center for Nursing today. I also want to mention that in terms of specialties, of our top 5 specialties of advanced practice registered nurses in our state, that includes family, which is care across the lifespan, adult gerontology, which goes from adolescence through end of life, but actually has a deep focus on the geriatric care, and adult, psychiatric mental health. So that is across the lifespan as well, but it does have that focus on mental health, behavioral health. And so in terms of determining capacity, decision-making potential of an individual, these APRNs who hold this national certification have an immense amount of training and competency in that area of care.
Thank you, Laura. Before we move on to Senator Baker, I just want to remind everyone that if you have any questions, you can type the question in the Q&A box on your screen, and we will get to your questions shortly. And so without further ado, we are very honored to be joined today with Senator Baker. Senator Baker championed the Our Care, Our Choice Act. It took a long time, but she got it passed. And now she's championing a bill to improve the law so that all eligible patients, even those who don't live in Honolulu, can access medical aid in dying. So without further ado, I hand it over to you, Senator Baker.
Thank you. This has been a great education for me. It's always nice to hear from Laura as well as the others about some of the shortcomings of our statute. And hopefully, even though this is going to be a very different session than we've ever had because of the pandemic, we'll be doing almost everything virtually, our committee meetings, accepting testimony. The Capitol, as you may know, is still closed. So you have to really be an employee or have a good reason for being there. You won't be able to access it. So I'm looking forward to putting this bill in. Our committee structure has changed a little bit. So I want to make sure that everybody has an opportunity to know that the new health chair in the Senate is Senator Jared Keoughly. And so if you have not had a chance to work with him or meet him, he's going to be I think he's going to be a great advocate for health and wellness across the spectrum. I'm his vice chair, so I look forward to helping him with that process, should he need any help from me, as well as I will still chair the Committee on Commerce and Consumer Protection. But yes, it will be my pleasure to introduce the bill. If you can give me the appropriate language, we'll get it drafted and get it put in. We convene on January the 20th, the same day that we get a new president in our nation's capital. And then I believe we will have about a week to introduce bills. So to the extent that we can get these done ahead of time, that would be a big help. But I appreciate the opportunity for the education. And if anybody has any questions about what we anticipate for the session, I will certainly try to answer them.
Thank you so much, Senator Baker. So the bill that we've been talking about today, it's the same bill that was in the legislature last session, last year now. It was actually inspired by the Department of Health's recommendation to the legislature. In fact, the Department of Health had all of the medical providers who had supported patients under the Our Care, Our Choice Act come together for a summit and talk about what their experiences were. And from that conversation, they realized that, the access on rural islands is extremely limited. And even when you do have access, as we've heard today, it can be very difficult to survive that mandatory minimum waiting period. And, I think it's important to understand that, people want the option of medical aid in dying because they want to die on their terms. And so, in some ways, I think it's almost worse to die during that waiting period when you're so close to being able to have that end of life option that you want. So what the bill does is it would include advanced practice registered nurses who have prescriptive authority to act as either of the two medical providers who are needed for the patient to be able to access the law. So as I said at the beginning, a patient has to make 2 oral requests separated by a mandatory minimum 20 days to the same, right now, physician, but we would like to include advanced practice registered nurses who already are qualified to be able to prescribe controlled substances like Laura talked about. And they would also be able to act as the consulting physician. This is the second physician who says that, who confirms the patient's eligibility, as well as the mental health counselor, because all patients have to go through a mandatory mental health assessment to make sure they're mentally capable and they aren't being coerced. So, this is a really important bill. There's no fiscal note attached to it. Last session, it actually passed 4 committees. It was assigned to 5 committees and it passed 4 of them before the pandemic hit. In fact, I was at the legislature with Dr. Miller when the World Health Organization declared COVID-19 a global health pandemic. And unfortunately, our bill didn't make it through. And I know there's a lot going on. There's a lot of news, quite a lot's happened. Even today, a lot of stuff's going on, but when you're at the end of life, it's so important to be able to die the way you want if you can. And I encourage all of you to help us. If you're interested in submitting written testimony when the bill goes to committees, it's so important to have your voice heard. So I'm going to share in the chat box right now my email address. If you want to be added to our action alerts for when that bill's at committee hearings, let me know and I will let you know so you can have your voice heard. So without further, Senator Baker, did you want to say something?
Yes, because this is the beginning of a new biennium, we have to start the bill over again. So we have to reintroduce it. So if you are fine with how it ended up going to getting ready to go to conference, we'll just start with that version and introduce it unless the Department of Health is going to introduce it as an administration bill.
Well, we'll talk to Department of Health, I think, offline. I don't know if Laura can respond to that or not.
Yeah, I'm going to have to check with Lauren on that, but certainly I'd be happy to represent the department.
Yeah,
because we convene on the 20th. We have a short window to introduce bills. So I really don't want to delay on this one. I want to make sure that we have the appropriate vehicle in. So if somebody can get back to me from the Department of Health, if it's going to be an admin bill, that's great. If you want it to be a Senate bill and we can give it to our House counterparts as well, just let me know. I want to get that. I want to get that done so that we can finish up on this and take care of the areas that need to be addressed.
Absolutely.
thanks.
I can get back to you. Thank you.
Thank you. Thank you, Senator Baker. Thank you, Laura. And I just realized I forgot one of the most important parts of the amendments is to be able to waive the mandatory minimum waiting period if the patient's unlikely to survive it. Oregon, who's had this law for 24 years now, has made that amendment to their law because they saw that a lot of their eligible patients didn't survive. And so that's part of the reason we've been talking about that statistic here today. The patient would still have to go through the entire process, but they wouldn't have to, sit around like the captain who Dr. Sharfin, described, just counting down the days until they can qualify. All righty, let's get to questions. Let me pull up the questions we have here. The first question is for Dr. Sharfin. How can we find a navigator on the outside? For example, someone on the island of Hawaii.
Oh, that's a great question. And it's something I've been trying to wrap my head around. So if you are outside of a big system, there isn't a navigator, right? However, what I have considered, and I'm still trying to figure out how I can make that work. We have a nonprofit called Life and Death Wellness. I feel like there is a way to have a navigator for our physicians and hopefully our nurse practitioners that are in the community, that we could maybe get a grant, share. I'm not sure the actual answer yet. I am always a resource though. I have told anyone that will listen, I've done this now enough that I understand the process. And I've kind of built my own small little team. So anybody on an outer island is always welcome to reach out to me. I will help in any way that I can.
Thank you, Dr. Sharfin. I'll also chime in and say that, if you're having problems accessing the law, please reach out to us. We have an end-of-life consultation line that we'll send everybody who's joined today a follow-up email with that resource. It's free, confidential. And I've shared my email address. You can always email me as well if you're having problems accessing the law, and we will try to help you as fast as we can. But we're also really trying to normalize this as much as possible so that people don't have to reach out to us to find a provider who will support them in the option. My next question is, how do you overcome objections to discussing medical aid in dying from close relatives based on their religious beliefs without offending them? Oof, that's a tough one. It wasn't addressed to anyone specifically. Does anybody want to take this question?
I'm happy to take that question. I'm actually dealing with that with one of my patients right now. Who, of course, she's got a nice support system, but one of her immediate family members really is opposed to this. And a lot of that, I think, goes to his fear of losing her. So the way I address this is I sit and I listen, and I don't make judgments, and I talk and I ask questions. And I think that's a skill that I've just learned over 20 years of being in the emergency department. And just trying to be an open vessel for people to be able to oppose this as well, right? So I think you've got to be able to balance that. It does always come down to the patient, right? They are the center of the care, but you cannot ignore their family or their support system. So for me, it's just really being open and being available. And especially with the telemedicine now, it is so much easier for me to have family conferences, to bring a group together or to talk to people individually and just make it okay for them to say, I don't agree with this. So that's my approach anyway.
Thank you, Dr. Sharfin. Does anybody else want to chime in?
I would just say that, I've had a couple patients as well in that position. And it's interesting. The family members we don't agree, but we respect his decision, which is ideal. I mean, you agree to disagree. And so it's been certainly reassuring for that patient that, feeling committed that this is what they want to do, and yet their family members necessarily don't agree. And it's proceeded fine. And it's it's, the patient's fortunate that they've got family members that can come to that resolution.
Thank you, Susan. Imagine family members not agreeing. All right, we do have a lot of questions here, so I'm going to go to the next one. Can an individual in Hawaii use primary care providers and psych assessment from mainland doctors, like someone from Seattle or other cities, to access medical aid in dying, or do all of the assessments need to be from Hawaii professionals? And I can go ahead and answer that question. So the provider does need to be licensed in the state of Hawaii. My next question, I think, is for Laura. Laura Reichart, in addition to advanced practice registered nurses, can physician assistants do medical aid in dying assessments? And the answer is no, but if Laura, if you want to expand on why, or Laura Arcibal.
Yeah, it might be better to have Laura Arcibal or Senator Baker respond to that. My understanding as a nurse is that because APRNs are independent and we have the ability to assess, diagnose, and prescribe under our own license, that is why we're seeking, our Care Choice is seeking to add APRNs, because we have that ability to practice independently under our own license and under our own assessment. But with physician assistants, it's a little bit more complicated because they have that oversight from a physician. Even though they do work using their own decision making, there is that level of hierarchy that complicates it. And that's my understanding, but I don't want to speak on behalf of physician assistants.
Does anybody else want to weigh in on that one?
I just want to make a comment in regards to the mental health requirement. Under the law, it specifically says psychiatrist, psychologist, and licensed clinical social worker. So I think if nurses fit within those categories, I believe we could make that work. But I'm going to defer that. That requires a bit more information, as well as with Laura, because she knows about the scope of nurses.
And I'll comment, there is statute in the Department of Health laws that specifically identify the specialty of psychiatric mental health. So it's not just the general APRN. And I can work with you offline on that.
Okay. The next question, will you provide the link to the recording so I can share it with colleagues? Yes, and please share this far and wide. And we have fact sheets and all kinds of stuff if you want more information that we'll send in the follow-up email. And this is another question, I think, for Laura Reichart. What's the difference between ARNPs, Advanced Registered Nurse Practitioners, and APRNs, Advanced Practice Registered Nurses?
That's a great question. ARNP is Advanced Registered Nurse Practitioner, and APRN is Advanced Practice Registered Nurse. So you can see, but it's just a transposition of one word there, or two words. APRNs are, their scope of practice is established by each state. So each state can pick what they call them. Sometimes they're called APNs, Advanced Practice Nurses, ARNPs, APRNs. There's even NP. It's very confusing. We use the national standard, which is Advanced Practice Registered Nurse. But essentially it is all of these people, ANPs, APRNs, ARNPs, have completed the same competencies. So they have a bachelor's degree in nursing, they have an active RN license, accredited education as an APRN, national certification, and then a state license. So they've all met the same competencies. There's just a little bit of alphabet soup going on.
Got it. Okay. Thank you, Laura. The next question is for Dr. Sharfin. And the person asks, you talked about being in favor of the requirement to waive the waiting period. Do you also support including advanced practice registered nurses in the law to be able to support patients?
Absolutely, I do. And actually, I testified last year on behalf of that in particular, because I had seen so many of the patients that had approached me not have access by physicians. And I know firsthand how limited we are on physicians. So I have always been in favor of this piece of the each piece of this legislation I'm in favor of, but especially the APRNs. And I think I testified to this. That's who I use for my primary care and my specialty care. I have worked very closely for 20 years with APRN, so I have no doubt that they can fill this role.
Thank you, Dr. Sharfin. Let's see. The next question is for Senator Baker. What will the hearings look like given that we are in a pandemic?
The hearings will be virtual, which means that you need a capital account, which is very easy to establish, so that you can submit your testimony in email, and then you will have access to the link when we hold the hearings.
Thank you. And we will send out information if you're interested in it. Like I said, please let me know if you want to be on our action alerts, but we include a video as well as something in writing on how to register. It's not difficult. It's pretty easy to do. And it's really tremendously helpful. I was going to mention too, the Kapuna Caucus is considering whether or not to have this bill be one of their priority bills. And, I'm excited that there's potential this could be a Department of Health admin bill, but if it's not, it would be great to have it be included in the Kapuna Caucus. And so I'm going to share a link. If you're in the Kapuna Caucus, or if you have friends in the Kapuna Caucus, they can vote on the Survey Monkey to have this bill be included. And it's the same bill as last year, SB 2582, as it was amended in the Senate Health Committee. Senator Baker, actually, your staff has had the Ledge Council redo it for 2021. So we got our ducks in a row pretty well as we can to try to get this bill through. All right, I guess I should go to the next question. Let's see. This is for Laura Arcibal. Are the numbers at other health systems similar to Kaiser and Hawaii Pacific Health's?
Well, I don't know how to answer that question. Yeah.
I don't know if you're at liberty to say.
Yeah, I can't, I don't think I would be able to answer that.
Yeah. I'll say, we have talked to all of the health systems and hospices since, we started reaching out since the day after the bill was signed the bill was signed in 2018. And it takes time. Implementation of this law takes time. And I would encourage everybody, I think one of the most important things you could do is talk to your provider as soon as possible and ask them, what is your policy for medical aid in dying? Are you allowed to support patients? Because there are hospices, certainly religious healthcare systems and hospitals, especially Catholic ones, some of them don't let their providers, their doctors, and hopefully eventually advanced practice registered nurses, but some of them can actually prohibit doctors from being able to support patients in the option of medical aid in dying. They can say, you're not allowed to support patients. And where you go for healthcare really matters. And so that's why it's so important to ask these questions, have these conversations early on and find out, if your doctor or nurse practitioner says, oh, I'll support you at end of life, no matter what, then be really direct and say, okay, well, if I qualified for this law, would you actually write the prescription? And see what they say. And if they say no, find out why they say no. Is it because they don't understand what the law is? We have lots of free clinical webinars. We're happy to share information. We have a doc-to-doc consultation line. We can put them in touch with doctors in Hawaii who have actually supported patients and can talk to them about it. But the best way, I think, to change policies and, make sure patients are supported in this is when they hear from those in those systems. So, it's kind of consumer advocacy, which is a weird term to use, but at the end of the day, it's kind of what it is, right? The majority of people in Hawaii want this law. We know that, but it's taking a long time to actually implement it. And again, I think, the Department of Health has done a great job in implementation. A lot of people have been working on this. And I think we have more questions, so I'll stop talking. Let's see. This is for Senator Baker. Someone asked, how can we help pass the legislation this year? And they might have asked that before I went on my monologue, but I don't know if there's anything you'd like to add, Senator Baker.
Make sure that once the bill is introduced and numbered, we start on January the 20th. Make sure that you contact your senator and representative to say that you support this measure. And if you feel so inclined, give us some testimony when we have the hearing.
Sounds great. Thank you. Let's see, we have time for a few more questions. Someone asked, can people with COVID-19 access medical aid in dying medication if they are dying? I am happy to answer that. With a COVID-19 diagnosis, patients tend to go very rapidly, and it's very difficult to get that 6-month prognosis or less, 6 months or less with a COVID-19 diagnosis. And, I should probably have Dr. Sharfin answer this. I see you shaking your head, and you could probably answer it better than me. So,
well, no, I agree. I think, no, they do not qualify for medical aid in dying. And I think that this is where making sure that we have all end-of-life options really talk to about a patient, having their advance directive, knowing if they want to be resuscitated. Actually, Compassion and Choices has a great COVID-19 addendum that you can add so that people understand what you would want if you got into that situation. But because, like you said, it can happen so rapidly, you can be talking 1 minute and not the next on a ventilator, this would not qualify under our Care Our Choice Act.
Thank you, Dr. Sharfin. And I'll reiterate that, if you go to Kakuamau is the Hospice Association in Hawaii, they have a great advance directive you can download and fill out. We also have advance directives you can fill out. But make sure you are having these conversations and talk to your loved ones, and make sure you have it in hand so that people know what you want for your end of life options. Let's see, I think we're getting towards the end. I think we have time for 1 or 2 more questions. If you're interested in volunteering with us, you can do that. We have, we can send around that link as well. Somebody asked about volunteering. What else can they do to support this movement in Hawaii? And I think that those are all the questions. I'm sorry if I missed any. Let's see. Yeah, I think I've gotten through. Okay, there's one last question from Dr. Sharfin. How can we encourage other healthcare systems and hospices in Hawaii to be supportive of medical aid in dying?
Speak out. The one part I didn't tell you about the captain's story is that he changed a system. And I think it's these stories that are so very important, and that's what makes a difference. And so because his system that he was in thought they had a policy, well, they actually didn't. I was able to go to that system and say, what is your policy? What's going on? And I got to share his story. And it was, it's been beautiful to see how they have changed the way they do things now. They have a written policy that all of their providers can be involved in the law if they want. They have actually gone out and actually focused specifically in Kona Hospital on better end-of-life care, not just for patients, but also for their staff. Mm-hmm. So please speak out, tell the stories. That your voice is the most important thing. And yes, talk to your doctors. I mean, a lot of physicians are still not educated. This is my world I live in, so I know it, but I sometimes have to remind myself, unless a patient has come to a physician, this is not at the top of their priority list. And that's how these things do change, though. It takes the patient, it takes the family to be advocates.
Thank you so much, Dr. Sharfin. And I realize we didn't get to quite all of the questions. We got to most of them, but we're at the end of the hour. And so Thank you all so much for joining today. Thank you to everybody doing this work. Thank you for being on this panel. We are so happy to all be together in this really important movement. So thank you and mahalo, everyone. Have a great day. Mahalo.